And it's my distinct pleasure and honor to introduce my next speaker, Dr. Patricia Weng. Dr. Weng graduated from Icahn School of Medicine at Mount Sinai and completed a pediatric residency at Yale New Haven Hospital in New Haven and a pediatric nephrology fellowship in Icahn School of Medicine at Mount Sinai. After several years as a pediatric nephrologist attending at Mount Sinai and New York Presbyterian Morgan Stanley Children's Hospital at Columbia University, she came to UCLA in 2013 and has risen to the ranks of Associate Professor of Pediatrics. She also serves as a program director for the Fellowship Training Program and the interim director for the Pediatric Kidney Transplant Program as well. So Dr. Weng, and she will be talking about role of genetics in pediatric kidney disease.
Thank you so much for that introduction, Dr. Rastogi. So I will talk about genetics in pediatric kidney disease and go through a couple of cases highlighting instances where it's really important to obtain genetic testing in our pediatric CKD population, and also relate that to adult nephrology and adult CKD. My only disclosure is that this presentation is being supported by Natera. So I'll first go into a case of an 18-month-old girl who's evaluated in the pediatric nephrology office for a history of gross hematuria, which is now resolved by the time the patient came to see us. The patient had a 1-week recent history of a URI that was afebrile. She had some rhinorrhea and a cough. Otherwise healthy, born full term, normal spontaneous vaginal delivery, no problems during the pregnancy, no significant past medical history or surgeries, no hospitalizations. On a repeat urinalysis in the office, she was found to have dark amber colored urine, over 1,000 red blood cells per high power field, no proteinuria, and a urine protein creatinine ratio was done, which was 0.4, which for her age group is normal. Further labs were all normal, including hepatitis, ANA, ANCA, complement levels. The rest of her CBC and her CMP were all normal. After much discussion with the parents, they opted to observe the patient, and the patient was seen every 4 months for the next year, yet she developed an increase in her urine protein to creatinine ratio from 0.6 to 1.0. The parents at that time refused a kidney biopsy due to the patient's young age and the parents' reluctance to have the patient undergo anesthesia at that young of an age. Over the course of the next year, the gross hematuria resolved but recurred between 5 and 6 times, usually associated with a URI, but sometimes it didn't seem to be temporally correlated with any URI symptoms. The differential diagnosis to our team was a post-infectious glomerulonephritis, IgA nephropathy, thin basement membrane disease, and possibly some other type of glomerulonephritis. At age 3.5, the parents finally agreed to have a biopsy done when the urine protein to creatinine ratio increased to 1.2. The biopsy showed on light microscopy some interstitial fibrosis. The immunofluorescence showed an absence of alpha-5 type 4 collagen and a mosaic patchy staining. EM showed diffuse thinning of a GBM and few areas of irregular and multilaminated appearance of the lamina densa, 1 sclerosed glomeruli, and mild effacement. The diagnosis was hereditary nephritis or Alport syndrome, autosomal recessive type on subsequent genetic testing. Clinical significance for this case is that Alport syndrome or hereditary nephritis does have, as we've heard earlier in this session, extrarenal manifestations, including sensory neural hearing loss and eye findings. Knowing the clinical diagnosis will enable us to counsel the family in terms of future family planning, to look for these extrarenal manifestations, and to see how carefully we really need to monitor kidney function. So genetics could have been aided in earlier diagnosis, which ended up being completely different from what the clinicians had initially predicted. So in this case, the genetic testing did not really coincide with what we thought would happen clinically. And this case, I think, reflects what everyone has been saying so far, that genetic testing is really important for therapy planning, family planning, and for looking for other extrarenal manifestations. that can impact the patient. So the benefits of knowing the genetics of a disease include heritability and family planning to actually know the precise, accurate diagnosis, for counseling for risk of recurrence after a kidney transplant, looking for extrarenal manifestations and monitoring of these extrarenal symptoms. And this can also help advance the understanding of biology and science involved in kidney disease, which can improve therapeutics in the future. So why is genetics important? The heritability of GFR, or glomerular filtration rate, is estimated to be about 30 to 60% in the general population, and other parameters such as also tubular transport of electrolytes similarly show substantial heritability. Moreover, about up to 30% of adult patients with ESRD report a positive family history across different ethnicities and etiologies. The prognosis, disease course, and appropriate management can then therefore differ markedly between hereditary and acquired forms of kidney disease. But these forms can be really indistinguishable when traditional diagnostics are done alone. So the cause of kidney failure is actually classified as unknown in more than 1 in 10 patients with ESRD. So thus, earlier and more specific diagnoses are needed to enable a delivery of effective care. So in terms of genetic epidemiology, there's a total of approximately 25,000 genes. Of these, they constitute about over 5,000 Mendelian disorders, and approximately 450 monogenic genes are known to cause CKD. Of these, 30% are known to cause CKD in the pediatric population. These are rare disorders, yet these genetic birth defects can constitute about 8% of live births. And up to 50% of individuals with rare genetic conditions can remain actually undiagnosed. Traditional genetic testing has been utilized to detect rare variants in individuals with suspected monogenic disorders. And traditionally, genetic testing has been used in the realm of prenatal screening and the diagnosis and individualization in cancer therapy. But more and more increasingly, the new genetic technologies are increasingly being applied in non-invasive kidney diseases and for prognostication in patients with kidney disease. So there are a wide variety of inherited kidney disorders. There are several hundred genes that are implicated in human kidney disease. And there are so many, for instance, just for podocyte biology, which can cause nephrotic syndrome, there are over 50 genes that are implicated. It's way too many for, I think, most clinicians to memorize and remember, especially also since many kidney disorders can also be thought of as complex or multifactorial, which is caused by a combination of both genetic and environmental risk. So with this wide spectrum of variety, where about 10% of ESRD has a genetic cause in adults and up to 70% of ESRD in pediatrics, it's really important that genetics play an important part in the workup of these patients. Just showing this slide, which has been seen, I think, in many different iterations in the past of causes of ESRD, where you can just see that the top causes of pediatric end-stage kidney disease are CACIT, or congenital anomalies of the kidney and urinary tract, which encompasses renal aplasia, dysplasia, hypoplasia, obstructive uropathy, and nephrotic syndrome, FSGS, and membranous nephropathy, congenital nephrotic syndrome. And I'll go into a little bit more detail in this talk about some of these primary causes of pediatric ESRD and how it relates to genetics. So monogenic kidney diseases can be classified based on the mode of inheritance, as we've heard earlier in this symposium, into autosomal recessive and autosomal dominant. Dominant disease genes may also be manifest by de novo mutations, which are also known as non-inherited mutations. This phenomenon is virtually absent from recessive diseases because it's extremely unlikely that you can have 2 de novo mutations occur in the same gene spontaneously. In recessive disease, both parental copies or alleles of the monogenic disease gene need to be abnormal or mutated for the disease to actually manifest symptoms. In recessive disease, this is often called full penetrance. An example of a recessive disease that we see in the pediatric population quite often is autosomal recessive polycystic kidney disease, and a dominant disease is autosomal dominant polycystic kidney disease. Just moving forward a little bit, just to talk a little bit more closely about the penetrance of these monogenic alleles in autosomal recessive versus autosomal dominant disease. You can see here in this chart, the x-axis shows the age of disease manifestation in years. And so you can see in the dark blue line, if you have a very strong mutation, i.e. a homozygous truncating mutation, which can be shown to be a very strong allele where the penetrance is quite high in an autosomal recessive gene, you can manifest symptoms at the age of 10 years. For another individual with a homozygous mutation in the same disease gene or a mild allele, the age of onset may be a little bit later, and you see the curve move to the right. The curve can move back forwards and to the right and to the left based on the environment too and other factors. So just a very incomplete list of some different types of monogenic kidney disease. For nephrotic syndrome, there's FSGS caused by MPHS1, MPHS2, nephrin and podicin, LAM2, TRPC6, alpha-actinin 4, which are more predominant in the adult population, causing genetic FSGS. CACIT, which can be monogenic or polygenic in its inheritance pattern, can be caused by a very large list, which I'll go into in the next slide, of genes that are mutated in SOL1, RET, PAX2, EYA1, and other renal tubular disorders such as Barter's, Gittleman, and nephrogenic diabetes insipidus. Some renal cystic ciliopathies that have already been mentioned in this symposium so far, ARPKD, ADPKD, they are all known to be to manifest through monogenic mutations. In addition, nephronophthisis, primarily a pediatric cystic kidney disease, which is caused by up to 20 different mutations, can also cause nephronophthisis. And then Bardet-Biedl syndrome, a syndrome that encompasses a renal cystic disease, and often these patients will require a kidney transplant or some other form of renal replacement therapy. There have been up to at least 22 genes at my last check that are responsible for the renal phenotype in Bardet-Biedl syndrome. So for polygenic diseases on the other side of the spectrum, it's characterized by a weak genotype to phenotype correlation. These diseases usually manifest in adulthood and have a weak heritability pattern, which is really subject to modification through environmental factors. So CACIT, the congenital anomalies of the kidney and urinary tract, I had mentioned earlier, can be caused by a monogenic cause, but it can also be part of a syndrome, and it can also be thought to have many different genes, and the environment can also impact the development of CACIT. I just listed a little bit the different types of CACIT that I'm talking about: renal agenesis, hypoplasia, cystic dysplastic kidneys, and vesicoureteral reflux. Nephrolithiasis, kidney stones, is also can be thought to be a polygenic kidney disease where there is a weak genotype-phenotype correlation, but there are some specific diseases that can cause nephrolithiasis and be caused by just a solitary gene mutation. So polygenic diseases can be characterized by a weak genotype-phenotype correlation, and it's usually manifest during adulthood as opposed to in the pediatric age group. This is just a slide looking at the different types of CACIT, and like I said before, up to about 20% of CACIT cases can be thought to be responsible by these monogenic gene mutations, and it can be part of a syndrome, yet it can also be this phenotype can manifest individually, separate from an actual syndrome. So CACIT is important because it can encompass about 40% of ESRD in the pediatric population. It's a frequent cause of birth defects, 1 in 1,000 live births, and there have been over 200 clinical syndromes that can have CACIT as part of the renal phenotype, and 40 different monogenic causes of human CACIT, 25 being dominant and 15 being recessive. Along the same lines, for glomerular disease, nephrotic syndrome can be caused by a single gene mutation, such as in nephrin and podicin, which I alluded to earlier, or it can be part of a syndrome, such as the ones listed here on this page. So just in terms of thinking about syndromes, I wanted to talk to you about my next case, which is a 3-year-old girl who had a history of renal dysplasia, was on peritoneal dialysis, referred for evaluation in my office for a kidney transplant. She received a kidney transplant after 1.5 years on peritoneal dialysis. Her postoperative course was pretty unremarkable, except for elevated blood glucose level in the hospital, which was thought to be due to steroids. Her creatinine was normal for age at 0.3, and her medications were the classic medications that we use after kidney transplantation: prednisone, mycophenolate mofetil, tacrolimus, cotrimoxazole, and valganciclovir. As an outpatient, she's continued to do well. Her blood sugars still ran high in the 250 to 300 range despite fasting. Genetic mutation was done 6 months after transplant, which revealed an HNF1 beta mutation. So at the same time as all of the whole workup for genetics and to see why she had persistently high blood sugar levels, the patient developed acute cellular rejection, received a steroid pulse and anti-thymocyte globulin for treatment. But unfortunately, due to this treatment that would reduce her immune system, she developed norovirus diarrhea, which hindered treatment. She didn't actually get complete treatment of her cellular rejection. Her cellular rejection continued, progressed. The diarrhea progressed. She had multiple episodes of acute kidney injury. We ended up decreasing her immunosuppression, her mycophenolate mofetil, and she eventually developed cellular rejection and aggressive antibody-mediated rejection in addition. So 1 year and 3 weeks after receiving a deceased donor kidney transplant, the patient was restarted on dialysis. So this case just illustrates that the parents were quite overwhelmed with the amount that they had to learn with their child having this new diagnosis of diabetes, in addition to having rejection and dealing with the kidney transplant. So it was just a stressful time for the family, and it would have been nice if we had genetic testing available to help with family counseling and planning and just realistic prognostication for the family. So HNF1 beta, just to quickly go over it, it's a syndrome which encompasses renal cysts and early onset diabetes. HNF1 beta is a transcription factor that's expressed in the kidney, liver, and pancreas. It's usually inherited in a dominant fashion. And like I said, it can cause cystic dysplasia, MODY, elevated liver enzymes, and you can also have magnesium wasting. So in this just pictorial, it just shows the different organ systems are involved with HNF1 beta, from the GI system to the kidneys and the CNS. So due to the strong genotype-phenotype correlation of almost 100% that's seen in renal recessive diseases, just wanted to talk about, again, how important it is that these patients get seen by a geneticist and by a genetics counselor and by a nephrologist. Especially in renal, single-gene renal disorders, it's important to know the diagnosis. That allows for prenatal diagnostics, can precisely reveal the primary cause of the disease. There's high diagnostic and prognostic value to this, and this really allows, in pediatrics especially, to have us undergo personalized medicine for our patients. Since the recessive mutations, like I said, conveys almost 100% risk that the patient will develop disease by the time they reach adolescence. An example of this is ARPKD. So there are a lot of overlapping symptoms and signs between the genotype and the phenotype, and this can be used to help inform prognosis and management. So for example, genetic testing can help distinguish between Alport syndrome and the related milder disorder, thin basement membrane disease. Both of these hematuria nephropathies do result from mutations in the COL4A3 to 5 genes. Despite such a high genetic and phenotypic overlap, the two conditions nevertheless differ markedly with respect to clinical outcomes. Alport syndrome patients really have a more severe disease with extrarenal manifestations such as audiologic or ocular deficits, which we've discussed earlier, and they can progress earlier to end-stage renal disease, requiring a transplant and/or dialysis. Importantly, the genotype level mutation can also help predict phenotype. So in general, biallelic COL4A3 and COL4A4 or hemizygous COL4A5 mutations result in Alport syndrome, whereas heterozygous COL4A3 to 4 mutations result in thin basement membrane disease. Thus, genetic testing can provide valuable prognostic information and guide further workup and management, such as informing the appropriate timing of transplant referrals and pursuing evaluations for visual or auditory symptoms among Alport syndrome patients. So shifting a little bit towards adult monogenic kidney disease, currently about 30% of CKD with the onset less than 25 years can be attributed to an established monogenic cause. However, there's significant variability in the reported prevalence of monogenic causation depending on the underlying actual CKD phenotype. And so Mallet in 2017 did a study using a gene panel of 207 genes. And these genes were sequenced in patients that had a familial nephropathy, and a monogenic cause was found to be detected in about 43%, about 58 of 135 families. So using this curated panel of genes, they could assess that there was a substantial proportion of these patients and these families primarily made up of adult CKD patients that ended up having a genetic cause for their disease. In another study using a whole exome sequencing analysis, Lata et al. In 2017 demonstrated that in 20% of adults with CKD, a causative mutation in a known monogenic CKD gene could be identified. Their cohort consisted of 92 patients with CKD attending a tertiary nephrology center in the United States, adults presenting with CKD with one of the following diseases that are listed there: glomerular disease, tubular interstitial, undiagnosed hypertension, or the developmental disorder, were submitted for whole exome sequencing analysis. And the cohort was enriched for patients with either a family history of CKD or undiagnosed CKD, like I said. So interestingly, using this method of whole exome sequencing, this actually led to the reclassification of diagnosis in 6 of 19 families, while this actually established the diagnosis in 7 of 19 families that were initially thought to be just unknown. So genetic testing can help in all of these regards in terms of actual precise diagnosis, confirming diagnosis, reclassifying, especially reclassifying from a family or a patient that is thought to have an undiagnosed mutation. It's quite important for them. So this is just another study that was done in 2020 by Hildebrandt's group, which looked at many different studies and the diagnostic yield that was being reported from adults versus pediatrics in terms of molecular genetic analysis for the diseases listed there: nephrotic syndrome, CACIC, chronic glomerulonephritides. Molecular genetic testing was performed by exome sequencing, or a gene panel sequencing was done. For disease subgroups with more than 2 studies, the median diagnostic yield is listed there, and that was used. Interestingly, there wasn't a huge difference in the number of patients that were diagnosed in adults versus pediatrics for some of these subtypes. And then this is just another study that was done out of Ireland, which looked at using whole exome sequencing in 114 patients that included 138 affected individuals with CKD. Affected individuals were mostly adults, and then they had a positive family history. Quite a number of them had extrarenal manifestations, and some had family history, some didn't have any family history. So it was a big conglomerate of different types of patients and families. They detected a mutation in about 37% of these families, and there was also about 70% of these families were found to have extrarenal features. So this is also shows that if you look closely at the slide, on the right-hand side, it shows that there's actually no difference in the rate of genetic diagnosis in individuals with a childhood versus adult CKD, which is very interesting. So a lot more still needs to be done in terms of research in this realm. Just skip over that. Okay, so just going quickly into specifically steroid-resistant nephrotic syndrome and the genetics of it. About 30% of FSGS is thought to be steroid-resistant and can present with recurrence in kidney transplant. The most commonly known genes are nephrin and potassium, which are listed here, which can cause congenital nephrotic syndrome and non-familial childhood steroid-resistant nephrotic syndrome. So genetic form is important to know because it can help with predicting progression to ESRD and the likelihood of recurrence after kidney transplant. And it can also help with guide with treatment. So if you have a genetic form, most likely you're not going to respond to steroids, and you can try to prevent the patient from taking steroids and having all the accompanying side effects of steroids. So this is just looking at the genetics of steroid-resistant nephrotic syndrome. There are 3 different studies done in 2015, 16, and 17. All of them use different curated gene panels looking at the genetics of nephrotic syndrome. And you can just see that there is just a much higher rate of a genetic cause to be found in the pediatric kidney disease patient versus in adults. So in terms of histology and genotype correlation, like I said before, there can be actually quite a poor correlation between the histological findings and the underlying actual genotype, which I discussed earlier with Alport syndrome. There's a huge phenotypic variability with the collagen genes, especially COL4A3, 4, and 5, which can have nephritis that may phenocopy as nephrosis. So the 2 studies that were done here that are listed with Sen and Mallet show that adult patients with nephrotic syndrome are often found to have mutations in an actual collagen gene. So this is just important to know in terms of therapies and predicting recurrence in the future for after transplant and looking at extrarenal manifestations in these diseases. Quickly turning to next generation sequencing, NGS or next generation sequencing is also known as massive parallel sequencing. It's an innovation that enables rapid and relatively inexpensive sequencing of multiple genes. And there's 2 different types of next generation sequencing that we like to use. Whole exome sequencing, which targets all coding regions in the human genome, and whole genome sequencing, which targets just the coding and the non-coding regions in the genome. And so the diagnostic yield for using NGS in pediatric kidney disease is quite high. Usually, so NGS has been listed as one of the reasons why we now know that copy number variations and neurocognitive defects are associated with kidney disease in children. So a lot of children have developmental delay, and this is thought to be due to copy number variations, and it can also cause renal dysplasia and hypoplasia, CACIT of all different types. And the copy number variation has only really come to light with the advent use of next generation sequencing. Next generation sequencing can also be helpful in diagnosing FSGS, renal ciliopathies, and MPGN or atypical HUS. It's, for example, the discovery of variants in the DGKE gene, which encodes intracellular kinase expressed in the endothelium, platelets, and podocytes among individuals with MPGN and or atypical HUS, has really helped us to better understand how signaling disruptions lead to endothelial damage, complement, and podocyte dysregulation. So in the last few minutes, I'll just go through another case. This was a case I saw, I think, about 7 years ago here in LA. It's a 4-year-old Asian male who initially presented with developmental delay at age 5 months, was evaluated by neurology for seizures, and EEG did show that the patient had persistent seizures. and had slightly decreased volume on a brain MRI. Clinical history, 2.5 years later, the patient developed generalized edema. The urine protein to creatinine ratio was 16. A urinalysis was devoid of any red blood cells. Albumin was low at 1.5. Patient was started on prednisone, a standard dose of 2 milligrams per kilogram per day, had no response after 2 months of treatment. The creatinine was a little bit high for age at 0.7. No significant past medical history, no consanguinity. The father's cousin did have a history of epilepsy, but no history of kidney disorders. Patient is not on any chronic medications at the time of the generalized edema starting. So the patient was biopsied, and it showed extensive foot process effacement by EM. 20% was completely sclerotic in the glomeruli, and there was partial consolidation of a capillary tuft and prominence of overlying glomerular epithelial cells and some adhesions. So we ended up doing genetic testing with whole exome sequencing, and we did Sanger sequencing for confirmation and found the patient had a new novel mutation, a nonsense de novo heterozygous mutation identified in TRIM8, which was disease-causing and caused the patient to have both seizures, developmental delay, and nephrotic syndrome. So the lessons learned from this case, knowing the genetic cause can really help with prognosis and genetic counseling. The parents wanted to know the likelihood that this gene would be passed along to any future children that they would have. Transplant disease risk, the patient actually is now transplanted and the disease has not recurred, most likely because he does have a genetic mutation. And we were able to really avoid immunosuppressive agents, which, as we know, have a lot of different side effects associated with them in this patient. So genetic testing can also lead to advancement of research and our understanding of nephrotic syndrome and other kidney diseases. So conclusion, there is a good proportion of kidney diseases that have a monogenic kidney mutation. It's much higher in pediatrics than in adults, but it's still important, I think, for the adult population to undergo genetic testing for the reasons I've outlined in the past. It can lead to disease reclassification. It's important for future family planning and for transplant outcomes, and also to monitor for extrarenal manifestations. Thank you. And I will take questions in the Q&A, and I will hand this back over to Dr. Rastogi.
So thank you so much, Dr. Wang. That was great listening to the perspective from a pediatric nephrologist. So a couple of points. So when we think about gene testing or genetic testing in adult patients, we normally tend to look at patients who have strong family history, familial, or they're actually younger adults. But as you heard from Dr. Wang, in pediatrics, they do a much more bigger, broader application for genetic testing. And the question that we need to ask is there a role for a broader indication for gene testing in our adult patient with kidney disease? And this we'll be discussing in our Q&A session. So if you have any questions, please put that in the chat box. We will try to answer as many questions as we can. We already have quite a few of them, but we would like to hear more.